we'll just minimize yours and get his loaded up.
Okay.
Get out of your way there.
It's on G or whatever. What is what is your clicker here on this thing? I'm not getting it. I'm not used to a Apple clicker at all.
Which one is it? This one? Hover over it, I'll get it from there.
They are in a different order here.
The suicide education?
Yes, but there were two different versions.
Can you hear me? Ooh, can you hear me?
Yeah, all right.
Am I talking into a microphone?
You can just run it right off your driver.
Yeah, I'll just run off the drive. It'll be fine.
Don't forget it, or it goes in my collection.
Yeah, that's right. Yeah, no, I don't forget them.
Yes, ma'am. But I have to leave to get that started. So, is there anything else I can do? Okay.
How soon will we get started for the recording?
Probably about 2 minutes, 3 minutes.
Perfect.
Less than that.
Okay, thank you so much.
There's some kind of glitch with my iDrive folder, and like a lot of I think with their IT is trying to help me, but I have to get back up there to see if they all sync to the iCloud. No, I didn't mean it that way. I just meant I'm just processing stuff. Hopefully all my Because the other thing is I've emailed to a lot of different people, but now the new rule is nothing's going to get saved after 3 months. It's like there's going to be just months and years of like, yeah, I don't have that.
I do email documents a lot, hopefully. Okay, I'll figure it out.
Okay, yeah, so that sounds good. Let's go.
Okay, are you all ready? You all can have a seat for just a second while I get us kicked off.
Hello, everyone, and welcome. Today we have a wonderful session planned for you. Before our session gets started, I have a little surprise. I've told some horrible, horrible lies to get wonderful, wonderful people here in the room. I would like to have Susan Sonning join Amy Holdhauser up here next to me. Susan's looking like, oh no. I'm asking them to come up because every year the LGBT Center has a very special award for people in our U of L community who have made huge strides and a commitment to being amazing allies to the LGBT Center and the LGBT community here at the University of Louisville. And what I'd like to say is that these two wonderful people, Susan Sonning in our undergraduate medical education research office, and Amy Holdhauser in undergraduate medical education, have been working tirelessly on a curriculum that is a national pilot for LGBT and DSD, or differences in sex development, curriculum across the nation. And this requires hours and hours of work that is above and beyond anything that they were tasked to do in their original job descriptions. And they're doing it because they feel like it's important, it's the right thing to do, and because it's the exciting thing to do as well, to really be the national leaders in being able to teach this curriculum. And it is my pleasure to get to work with them. And I'm thrilled to give them awards today as this year's chosen U of L LGBT Center's Ally Awards. And I'm going to ask Z here to say a couple more words.
Hi, I'm Rhiannon Ledgerwood. I'm a second-year med student, for those of you who don't know. And I just have to say, like, going to a school where we have a program like this is not only incredible, but it to be the first in the nation, like, that's just beyond amazing. And the fact that you two have put so much work into this and have, like, spent so many countless hours just to make this happen is just incredible. And I just wanted to thank you. Me, personally, I wanted to thank you from, like, the bottom of my heart for doing this and making our school one of the best in the nation. Thank you.
So Amy's saying, wait, you don't really need me? I told her that she was here to introduce our speakers. And indeed, I would still love for you to introduce our speakers. And because I surprised them at the last minute with this, I'll simply say, if you'd like to say a couple of words, you're welcome to. We will have to keep it brief since we have a presentation here today. But I'll pass this off to Susan first, if you want to say a couple of words. And then Amy, if you would introduce our speakers, that would be fabulous.
Well, Stacy is quite the trickster because my responsibility was to get Amy here, so that's a surprise. And I also literally walked out with my hair wet this morning, so I think I would have prepped a little bit. I just want to say thank you. It's an honor to work alongside of Stacy and Brian and this team. It's meant a lot to me, and it's meant a lot to the whole School of Medicine. And I feel very proud when I talk to people nationally and talk to people locally and tell them what we're doing. Everybody's so excited, and really thinking about the patients who are going to benefit from this project is really what drives all of this. And I'm just so happy about it and very thankful, and very thankful again for Stacy's work and Amy and the entire quality team. So thank you very much.
Thank you, Susan. Susan has worked so hard. So just two observations. One is this started as a curriculum project, but because it's generated a lot of national excitement and kind of catapulted U of L as an institution forward in the news in so many ways, it's resulting in things like the conference call I was on Thursday to try to create a medical home, a clinic, and an associated network of doctors of all different specialties and mental health professionals and social workers for our LGBT and DSD affected patients here in Louisville. And there isn't, for a city its size, there isn't a center like that. There isn't a resource like that. And I don't have a training center to send students to. So it's very exciting that this is moving beyond curriculum. It also reflects how little people, I think, even very well-meaning people in positions of administrative power understand about this, because the head of ULP was on this conference call, so it's University of Louisville physicians, and asked me, but said, but Dr. Holthauser, aren't you teaching this now? I mean, do we really have to create this? Like, you're the answer. And I said, well, I'm the answer, but it's an 8-year process. Like, the people I'm teaching now are going to be able to treat patients better than we treat them currently in 8 years. And the community needs something now. So that was the first observation. The only other observation I would have is how much I've learned through this process. And if you'd asked me a year ago, so yesterday was National Coming Out Day. If you asked me a year ago, I'd be like, yes, bye-bye, yay, wonderful, National Coming Out Day. That's so awesome. And I really am appreciating that I've gotten to expand the diversity of my Facebook friends as part of this process, that it's been that because I've been doing this, I've been identified now as somebody that's safe to come out to, or to befriend, or to kind of discuss and enmesh in the more complex issues. Because almost to a person, every one of those people that is out was happy to be out and said, if it is not safe for you to be out, please don't be out. And so please recognize, as you're sitting here, we still live in a place, a society, an environment, a city, a state, a country, a world where it is not safe to be out for the majority of our community. And that's what we're here to change and fix. Thank you. Oh, sorry. First up, Dr. Talawi is a third-year doctoral student. Oh, you're going to be, though. He's going to be a doctor one day. I can call him that when I call him in class. Near Dr. Talawi is a third-year doctoral student in the clinical psychology program at University of Louisville. Our psychology department, by the way, is extremely supportive of the community, and one of our strengths here is the university. Ms. Talawi researches OCD and LGBT issues at the Center for Mental Health Disparities, has published several manuscripts and book chapters, and presented posters on OCD and issues affecting ethnic and sexual minorities. Thank you very much for coming. Melissa Ellsworth is a third-year doctoral student, also in the clinical psychology program at the University of Louisville. Ms. Ellsworth researches the impact of stress on physical health outcomes and the role that mindfulness-based interventions has in mitigating poor health outcomes, including chronic pain and illness. She's also interested in how these interventions can help buffer against minority stress and poor mental and physical health outcomes in LGBT populations. Ms. Ellsworth has published manuscripts and presented posters on mindfulness and self-compassion in various clinical populations, as well as addressing treatment barriers in ethnic and sexual minority populations. Thank you so much for being with us. The podium mic works just fine. You won't hear yourself, but it works.
Can everyone hear me? Yeah? Okay. So how does this get up there? Is it?
Potentially, yes.
Sorry, we're...
It should be on the desktop.
Okay.
Not coming up on the sides.
This
You know how to bring it up on the screen. It is. Do you know how to do that? There is an option.
breakout mic? Or...
Maybe. Yeah, that'd be great.
Sorry, guys. Technical difficulties. I should have figured that out beforehand. Whoops.
Do you guys want to start talking about general stuff, or start off with the
We start out with a picture.
Is it on the major thing? That's right. That thing? What are you pointing at? Sorry, excuse me. Side by side. Oh yeah, that's what I was trying. So. Thank you. Hello. Sorry.
Where are we at? You're trying to get this onto the those screens. Oh, gotcha. No problem. So we'll plug in PC.
There we go.
And there we are.
Awesome. Thank you so much.
Here. Woo! Thank you. Okay. All right, everybody.
Is this on? Okay. So we're going to be talking about mental health disparities in lesbian, gay, bisexual, and transgender populations. We know there's also a Q, queer questioning, but just for the ease of the research, this is how we'll be talking about, although this can also include queer and questioning populations as well. I'm Melissa. This is Gazelle. Okay. How many of you guys are familiar with the genderbread person? Good. So this is, I think, a really good illustration of how complex the sexual identity can be. For a long time, we thought sexual identity was very dichotomous. It was, either or gender presentation is dichotomous. You're a guy or girl, or you're gay or not, or whatever. We realize that it's way more complex than that, and you can see how many different dimensions it can range on. So gender identity and expression in terms of how you identify, how you present yourself, biologically how you identify, who you're sexually attracted to and who you're romantically attracted to can all vary, and these are not mutually exclusive. So the other thing, too, what's nice about this version is that there's the no sign down there because some people don't identify with these terms at all. Some people don't identify with the term feminine or masculine. And so what this basically really illustrates is that our clients, our patients that are LGBT really can be, or even or not, can be really variable in terms of all of these different dimensions. Something to think about when you think about the complexity of these issues and how mental health issues might interact with this.
All right, is this mic working? Okay, so to highlight the need for this talk, I'm going to go into some specific mental health issues that these populations face. And can everyone hear me back there?
Do you want the
No?
external mic?
460.
Just use that one. It's probably easier.
How about now? Not yet? How about now? Yeah. All right. I haven't talked into a microphone since I was in 8th grade, so. All right. So I'm going to go into LGB issues first, and then a little bit later we're going to talk about transgender issues. So LGB individuals face disproportionately higher rates of mental health disparities. Depression and anxiety is a major issue in this population. A recent national study found that LGB individuals are 1.5 to 2 times more likely than heterosexual individuals to report lifetime mood and anxiety disorders. This is often more severe for men who remain in the closet. Additionally, women with same-sex partners experience more mental health disorders like major depression, phobias, PTSD than do women with opposite-sex partners. And one potential cause of these issues is trauma, as LGB individuals are more likely to be targets of trauma, particularly interpersonal violence, than their heterosexual peers. And body image and eating disorders are also issues in this population. Beginning as early as age 12, LGB individuals might be at higher risk of binge eating and purging than their heterosexual peers. And in order to cope with some of these issues, many individuals might turn to substance use and other maladaptive coping methods. So gay men use substances, including tobacco and illegal drugs, at higher rates than the general population. And this increased use can be related to risky sexual behaviors that promote poor health outcomes, so increased risk of HIV transmission and other STDs. And gay women are also 1.5 to 2 times more likely to smoke both tobacco and marijuana than heterosexual women. And bisexual men and women seem to have the highest smoking rates of any subgroup for which data is available, between 30 and 40%. And so with all these issues, a lot of times it can seem like suicide is the only escape. So there are higher rates of suicide attempts and completions among gay men and youth than among other populations. And factors like verbal and physical harassment, negative experiences related to coming out, and level of family acceptance all can contribute to these differences. Additionally, lesbian, bisexual women who are out experience more emotional stress as teenagers and are 2 to 2.5 times more likely to have suicidal ideation than heterosexual men. And then this is also an issue in youth populations as well. So while LGBT youth make up about 10% of the teen population, they make up about 1/3 of all teen suicides.
Okay. So as you can see, there's a lot of mental health issues in this population. And in order for us to understand potentially theoretically why this is happening, a really prominent theory that has been developed by Ilan Meyer, I think I'm saying that Ilan, is minority stress theory. How many are familiar with minority stress theory? Okay. So minority stress theory explains one reason why LGBT individuals may experience higher rates of mental health disparities than others. And basically what the theory says is that individuals who are of a minority status, such as race, ethnicity, sexual orientation, or gender, are more likely to face stigma, prejudice, and discrimination that over time cumulatively can lead to poor physical and mental health effects. And while we all have general stressors from our environment, minority individuals have the additional component of minority stress that, as a result of these stigma, prejudice, and discrimination, that leads to these difficulties. And I'm going to go into more detail about what this model is. So this is an illustration of the minority stress model that Meyer had put together, and it's really kind of a good depiction of how all of these variables interact. So as you can see here, you have minority status, like a disadvantaged status, which could be sexual orientation, race, ethnicity, and gender. And your identity can have these kind of 3 different components: prominence, valence, and integration. Prominence is how much that identity combines with other identities this individual might have, such as a racial and ethnic minority identity. Valence is whether it's a positive or negative identity. Integration is the first one. Prominence is how important it is to them. But basically what that is saying is that the identity and how salient it is, whether it's positive or negative, and how it integrates with interacts or conflicts with other identities, can affect kind of all the other variables too. And as you can see here, circumstances in the environment, general stressors, this is stuff we all face, you know? And so you have that, and then on top of that, you have minority stress processes, which can be distal or proximal. And distal stressors are the external environment, such as discrimination, prejudice, and stigma in the environment. And then this can flow into proximal stressors, which is more internalized stress, such as expectations of rejection, concealment of identity, and internalized homophobia or transphobia. And then depending on the coping and social support of the individual, whether they have good social support, good community support, this could lead to poor or negative outcomes. So as you can see, all of this kind of combines together and flows into positive, negative mental and physical health outcomes. And Gazelle is going to talk more about these individual stress processes and the research that supports it.
All right, so as Melissa touched on, distal stressors are these external sources of stress that are usually experienced in the environment, like discrimination, prejudice, and victimization. So research suggests that LGB individuals are twice as likely to experience a prejudice-driven life event, like losing a job or other workplace discrimination. A quarter of LGB participants report experiencing criminal victimization, like physical or sexual assault, as a result of their sexual orientation. And this affects youth as well, because LGB adolescents are bullied by their peers more frequently than their heterosexual peers, and they're more likely than adults to experience anti-gay prejudice events. And the psychological consequences of this victimization can be more severe in youths than in adults. And as a result of all these experiences of discrimination, roughly 28% of LGBT students drop out of school because of assault, verbal abuse, and isolation. And this is also something that really affects transgender individuals. They report higher rates of physical and sexual violence, with about 43 to 60% reporting physical violence and about 45% reporting sexual violence. That's just, ridiculously high. That's about half of that population. And 20% of transgender individuals have been denied jobs, and 13% have been fired because of their gender status. So these distal stressors don't have to be overt. They can be experienced as microaggressions, which are these more subtle forms of discrimination. And one researcher put it so well that we had to quote this researcher. LGBT people are subjected to a stream of nearly continuous microaggressions in the form of denied civil rights, religiously tinged hate speech, and political campaigns aimed at stripping them of those rights that they do have. So we thought that really summed it up really nicely. And then proximal stressors are those that are experienced within the individual. So the first of these is internalized homophobia or transphobia. So this is when the individual directs society's negative attitudes towards LGBT identities towards themselves. And this is associated with all sorts of negative things, including depression, anxiety, substance use, suicidal ideation, self-harm behaviors, eating disorders, HIV-related high-risk behaviors, and it can affect intimate relationships and sexual functioning. So basically, every single thing we don't want our clients facing can be a result of this internalized homophobia or transphobia. The other thing is rejection sensitivity. So this is thought of as anxious expectations of and overreactions to rejection based on one's stigmatized status. And it can cause LGBT individuals to become hypervigilant and kind of expect discrimination, and this can really lead to interpersonal difficulties. And studies have shown that it's associated with internalized homophobia or transphobia, lack of assertiveness, depression, and anxiety. And then the final proximal stressor that we're going to get into is concealment. And this is when an individual hides their LGBT identity to avoid public stigma, ostracism, and rejection. And researchers have found that concealment is linked to significant psychological distress, intrusive thoughts about the secret, and then shame, guilt, and anxiety about being found out. And concealment can be really problematic because affiliation with other individuals from one's stigmatized group can be really can have a positive impact on one's self-perception, and concealment kind of limits the possibility of having this affiliation, and it limits access to support resources and protective factors. And While it has been linked to all these negative outcomes, concealment or coming out isn't always an option, as was mentioned earlier, because we do live in a society where being LGBT is still not accepted. So concealment can actually be beneficial when the individual doesn't have access to social support, or they can't expect acceptance from their environment. So this is why it's so important to meet our clients where they're at. And as far as transgender individuals, there is really almost no research on proximal stressors in transgender individuals. One study found that more than half of their transgender participants conceal their identity to avoid intimidation. And it also results in decreased access to health care. And it's thought that these beliefs about the self and experiences with distal stressors function the same as they do in LGBT individuals, as they do in transgender individuals. And so outcomes of minority stress as a whole, individuals who report high rates of minority stress are 3 times more likely to report psychological distress and more physical health problems, higher symptom severity, and poorer overall health. And then perceived discrimination is predictive of anxiety and substance use disorders.
Okay. Now we're going to talk about a couple of special considerations, particularly for bisexual individuals, and Gazelle will talk about transgender populations. There's research to suggest that bisexual individuals actually have the lowest level of emotional well-being among all sexual orientations. There's actually research to suggest they have higher levels of self-harm, thoughts of suicide, and suicidal attempts than heterosexuals, gay men, and gay women. There's evidence to suggest that the reason why this might be is because they have unique experience with the discrimination, including stigma and stereotyping that are specific to their bisexual identity and differs from gay women and men. And there's some issues with the fact that not only do they experience some discrimination and prejudice from their heterosexual counterparts, but also from within their community, from other gay individuals as well. So there's something to think about if you ever have a bisexual client, that they might have some disproportionate rates of mental health disparities as a result of potential even greater loss of community.
All right, and so we put transgender mental health on its own slide because the rates are so much higher than LGBT populations and the general population. So roughly half of transgender individuals experience significant symptoms of depression, which compares to 9% of the general population. So that's a lot higher. And then 47% of transgender men and 40% of transgender women report clinically significant anxiety symptoms. A high estimate of anxiety disorders in the general population is about 23%. So this population is still showing much higher rates. There's also a lot higher rates of PTSD symptoms. In the general population, it's about 5% of men and 10% of women reporting PTSD symptoms, but it's about 18% in transgender individuals. And this is a result of a lot of the distal stressors that we talked about earlier. And then the rate of suicide attempts is wildly high. 46% of transgender women and 42% of transgender men report attempting suicide. Family response is also very important, as individuals who lose their family support, 57% attempt suicide. And then this just to give some context, the rate of suicide attempts in the general population is 4.6%. So this is about 10 times higher. And even in LGBT populations, it's only 10 to 20%. So we're still much higher in the transgender population. And then as healthcare providers, we're in the unique position of we have to be very sensitive because 60% of transgender individuals report attempting suicide when a doctor or healthcare provider has refused them treatment. So we have to be very aware of this fact. All right, and so here's a graphic from the Fenway Institute about Transgender Awareness Month. So it kind of covers some of the things that we've already talked about. It says that 65% of transgender individuals report discrimination in one or more public accommodation settings. So, things that we take for granted, like public transportation or going out shopping, these are all situations where transgender individuals actually face discrimination. The other thing is higher rates of HIV infection, and something that I thought was really interesting is about a third report having to teach their healthcare provider about transgender issues. So we're all getting a leg up by being aware of these things here. Okay, and so a little bit on understanding the current diagnosis. So this picture isn't the only depiction of gender identity. It's just one that we thought was kind of good to illustrate how a transgender individual may feel. So in the DSM, which is our diagnostic manual, in the last edition, it was known as gender identity disorder. But in 2013, in the DSM-5, it was changed to gender dysphoria. And this is kind of to reduce the stigmatizing effects of a label that carries the word disorder, and also to kind of shift the emphasis from the identity itself as being a disorder to the stress related to the incongruence between what's experienced and what's perceived by other people. While it's still stigmatizing, a diagnostic term is necessary because it protects the transgender individual's right to care, and diagnosis is necessary in order to receive insurance coverage for medical procedures. So we wanted to touch a little bit on what the process of transitioning looks like, but there really aren't clear guidelines. So the World Professional Association for Transgender Health puts out kind of standards for care that are highly suggested, highly recommended, but flexible based on experience, based on the individual's unique situation. So, there are things that are recommended, like seeking psychotherapy before transitioning, taking hormones for a certain amount of time before surgery, or living as the preferred gender before undergoing surgery. But there are no set in stone, like, you have to live as the preferred gender for a year, or anything like that. And however, when you do get into the surgical procedures, there are some guidelines, like needing a referral from a mental health professional who has done a thorough assessment and that kind of thing. But really, it's kind of a gray area, and it's kind of difficult because an individual can access hormones illegally, and so it's really important that we provide care for these individuals so that we make sure they're going about this in a healthy and safe way.
Okay. Now I'm going to talk about assessments that you guys could use for your patients that I feel like, there's a lot of different kinds that you can use, but this is one we actually use in our clinic, and it actually is pretty much it's pretty comprehensive and relatively efficient to administer and pretty self-explanatory in terms of scoring as well. This is the Outcomes Questionnaire 45, and this is version 2. It requires no instruction beyond those printed on the answer sheet. And before you guys leave, I actually printed out a bunch of them on each end of the tables here. If you guys want to actually grab one, and then there are scoring instructions on the back that tell you about how to do that and critical items. But it takes approximately 5 minutes to complete, although it can take up to 15, but most people complete in 5 to 10. It's something that they can complete in the waiting room while they're waiting for their doctor. It assesses 3 dimensions of mental health, including symptom distress, such as depression and anxiety, which we know is really important to assess in this population. But it also assesses for interpersonal relationships, like loneliness, conflict with others, romantic or family difficulties, which is also important to assess, and social roles, such as difficulties in the workplace, school, or home, which can kind of get at that difficulty with potential discrimination or potential prejudice. And then you give it a total score, and you can look at the subscales. And it also assesses for critical mental health indexes such as substance use, suicidality, and homicidality. So given what we know what LGBT individuals face, this is actually a relatively good measure for kind of getting at all of those things. So you guys can pick up one of those when you leave. Yeah? It's a general. but good to use. Yeah, we actually had difficulty finding one in LGBT populations, except for in youth, which wasn't going to be able to be, yeah. So, but we felt like this one could tap into a lot of the issues that they struggle with. Okay. So mental health treatment for LGBT individuals is also varied. So psychiatric treatment and medications, just like anybody, some individuals may need psychiatric medications, although we have to be careful not to just dismiss any mental health issues and say just take an antidepressant without considering things like psychotherapy, which is our bread and butter. And a lot of times a good psychotherapy process will look at gender and sexual identity, role and expression, address the negative impact that LGBT status and stigma can have on the individual's mental health, like looking at gender dysphoria, exploring the role of other types of identities. So a lot of clients that we might have religious identities and ethnic and racial identities that might conflict with their LGBT identity. So exploring and kind of negotiating that kind of integration and talking about how that plays out for them. And then also addressing and alleviating internalized homophobia and transphobia, and discussing issues with concealment and whether it's safe to conceal or not, and whether there's, some individuals can conceal to some and not to others, or disclose to others. And so talking about that and what that looks like. And enhancing social support, which is really important in this population because a lot of these individuals will face isolation from their families or religious communities or friends as a result of disclosing their identity and might need other community resources or social support from, like, say, the LGBT community in the event that they want to disclose information. So kind of talking about that, what that will look like, and helping giving them resources is really important. Okay, so I'm going to talk about some overall ways to be culturally sensitive and best practices in a healthcare setting with LGBT individuals. And so though most healthcare professionals today have positive attitudes towards the LGBT community, people still face unequal care due to a lack of training or understanding of this population. And also, healthcare providers don't always have up-to-date knowledge of the unique needs of the LGBT community or training on LGBT mental health issues. So sometimes it's just, we just don't know. But we want to know, so that's why you guys are here. Further, providers who lack the knowledge and experience working with members of the LGBT community may focus more on a person's sexual orientation or gender identity than a person's mental health condition. So kind of figuring out how to navigate that is really important too. So here are some treatment recommendations. Of course, these are not all of them, but these are just some to keep in mind. Don't be afraid to address sensitive topics, such as sexual history. Sexual orientation or gender identity as well. It may or may not play into the person's presenting mental health complaints, but it's important to ask your patients and your clients and to get comfortable talking about it because we don't know how much of this interplays with the mental health, that mental health stress that they might be facing. So it's important to just ask and be mindful of that. And also be mindful of your own stereotypes, assumptions, and biases. So assumptions of sexual orientation and gender identity based on appearance, don't do that. Be aware that gender and sexual orientation, self-identification, and behavior do not always align. So even if a person doesn't identify with a sexual orientation label, that does not mean that they're not engaging in same-sex behavior, and that's important when you're assessing for sexual history and other things that may be related to their health. So just keep that in mind, that those don't always align. And always ask open-ended questions in terms of kind of like getting out information. Don't necessarily like basically say like, oh, are you gay or something. Like let them kind of like, talk about it in their own way. Be aware of a patient's mistrust of the medical and mental health profession and the subtle cues you may be sending. This one is really important. Remember, there was a time when the mental health profession pathologized LGBT identity. Homosexuality was considered a mental illness not that long ago, and we define gender identity disorder as a disorder. Now it's dysphoria. So keep in mind that there might be some mistrust there. And then also, nearly all LGBT individuals at some point in their lives have or will have disrupted relationships with friends, family members, or religious communities by disclosing their sexual or gender identity. And so many of them are extremely aware of possible cues that you might be sending whether you are accepting or supportive of them. So this is kind of gets back to what we talked about earlier about rejection, sensitivity, and microaggression. So be aware of the subtle cues that you might be sending. And some ways you can do this is create an LGBT supportive environment, such as hanging up a pro-LGBT flyer or the Safe Zone sticker, which is something that you can actually get from the LGBT Center as soon as you complete Safe Zone training, which is a relatively brief and very good opportunity for you to become an ally. So this is a really good example of that. Next thing is to use inclusive language and know your terms. I know this is kind of always adding, but know them. And ask the client about their own terminology preference, such as pronoun preference. And this can help build rapport with your clients. And use your client's language. Don't assume that they just because they're in a same-sex relationship or they have same-sex behavior that they want to be called gay. Allow them to actually use the terms that they prefer. And if you're not sure, use neutral language. Ask, are you in a relationship right now, rather than do you have a boyfriend or a girlfriend, or use the term partner. And then, again, ask questions and welcome and normalize disclosures. Never assume your client's going to tell you information openly. Ask your patient to clarify any terms or behaviors which you're not familiar, or repeat a patient's term with your own understanding to ameliorate miscommunication. This can help you learn. So if you're willing to ask your patient, this actually helps you learn about this population as well and how you can best serve your clients. Also, a disclosure of LGBT identity can be welcomed by just simply saying, I'm glad you told me that. Or if they disclose something that's difficult for them, say, that sounds difficult. How do you feel about that? And it can show that you're comfortable and interested in their disclosure and you're interested in building rapport and showing support. This can also help you get information that you might need to understand if they have mental health issues or how they might interact with their whatever issues you're assessing for. But also be aware that disclosure is an individual process, and sometimes an individual is not ready to disclose. They might not feel comfortable, but just make them feel like it's a safe space so that they know that they can if they want to. Express and maintain confidentiality. Confidentiality is the cornerstone of our patient-doctor relationships or healthcare provider relationships, and is crucial when assessing and treating LGBT individuals, especially when a lot of these individuals might be afraid of being outed or people finding out about their identity if they aren't ready. So make sure that you tell them that this information is confidential. However, also let them know the limits to confidentiality, which we have as, risk of harm to self or others, abuse and neglect. Just make them sure that they know what those limits are and what they tell you will be confidential and what won't be. And then avoid both over and under pathologizing. So given our tendency, the mental health field tendency to pathologize same-sex desires, gender discordant identity, some care providers may interpret these as mental illnesses or more related to mental illness than they really are. So don't over-pathologize. In many cases, our patients' effort to understand their sexual and gender identity is a source of resilience for them, a source of strength, and should be supported. But however, by contrast, it's not always ready to be celebrated. A lot of times, a sexual and gender identity might be a source of great distress for this individual. And depending on where they are in their identity formation, we have to kind of meet them where they're at. So just kind of try to keep it very open and supportive for them. Okay. And then also be familiar with mental health referrals and resources, which we will get into next. So this is just a general template of what referrals you can make for mental health professionals, and when, where, and who. When, we kind of already talked about this: suicide and homicidal ideation, requests for psychiatric medications, trauma, addiction, comment about life issues, all the things we already talked about related to what's affecting this population. You can make these referrals. You should make referrals for mental health professionals when you hear about these things. And there's different levels of care, and depending on the severity, duration, and type of problem that the individual might be facing, it can vary. So inpatient facilities are typically used for more severe mental health issues. Suicidality is a really common one. Partial hospitalization programs or intensive outpatient programs is another level that's kind of stepped down. A lot of times these can be related to substance use treatment also. And then outpatient is typically like psychotherapy and other types of issues that the person might need. And types of providers are also variable. So psychiatrists usually prescribe medication, short-term therapy. Psychologists can provide therapy also, and assessments. Both can provide diagnoses for like gender dysphoria if you have a transgender client and who needs that diagnosis for further care. And counselors and social workers can also provide psychotherapy and also community resources and getting the client in touch with resources in their community that can help them also. So keep those in mind. And resources, you all have a handout, or should have gotten one. There's also some on the ends of the table. The resources that I put on there, it's just one page. We have lots, and so if you guys want to email us, we can give you more. But those are the ones we felt were the most comprehensive in terms of websites and phone numbers that will be useful for not only you, but also for your patient to be able to access directories for medical providers that are LGBT friendly, and also hotlines, phone numbers that where LGBT individuals can call if they're in distress and crisis for suicidal ideation and things like that. So having that will be really important. So, do we have time? Okay. Do you guys have any questions? Yes. So she asked, what are some some treatments that might help them get better in psychotherapy? Honestly, it kind of goes back to that slide we talked about in terms of talking about them and about their sexual identity in a way that's very normalizing. So if, depending on where the individual is at, as we saw on the minority stress slide, where they are in terms of their integration of their identity and their identity formation can vary. So it really depends. And I think the best answer is to ask what it is that they struggle with, what it is that they're having difficulties with. It can be a good example from our case study is that, a lot of times our clients have an LGBT identity and then it conflicts with something else, such as their religious community or their family is not supportive of them and they don't know what to do. So helping them kind of basically just navigate that conflict, that potential, distress that's causing them, and helping them work it out and figure out what is the best way to kind of move forward on that, because that can be a really hard thing, and depending on where they are, it can vary in terms of whether they're ready to come out. Because just because a person is LGBT and they want to come out doesn't mean it's safe for them to come out, and therefore they might lose their family as a result of that. So really just trying to figure out where they're at, and then also make sure that they know that they have at least one person that they can safely talk with, that they can disclose that with, and creating a very open and safe environment, and always kind of validating their experience wherever they're at, whether and also if they are talking about coming out or wanting to disclose or wanting to make a change in that regard, make sure that they have support. A lot of therapists, I don't think they realize that that's really important. A lot of these individuals, they want to come out, they're really distressed by it, but they might lose their family, they might lose their religious community, and so pointing them in the direction of the LGBT center here or the one on campus or where we're at, ways that they can get in touch with other people so that they can kind of navigate that process with other individuals who might have gone through it, and how can they overcome that, because the thing is that once they come out, they might face a new wave of depression or isolation that comes from that they really need social support for. And that was probably way longer than you needed. But did that help at all? Okay. Yes? Absolutely. And actually, there is research to suggest they have much higher rates of shame in that population. And I've actually read a study that there's high rates of suicidality in those who have comorbid diagnoses. So, yeah, that's definitely something to take in consideration, especially when people have assumptions about who is affected by HIV. And so I think that being really aware of that there is another element there of stigma, definitely, and then also internalized stigma. So a lot of times individuals with HIV, regardless of LGBT status, feel shame about the disease because it's a shaming disease for a lot of people. And so I really kind of understanding that interaction and the shame. And so a lot of the work that I do, for example, with mindfulness and self-compassion is related to kind of not judging the self and not tearing the self down in terms of that shame, because a lot of the times we are not going to always have people in our environment that'll do that for us. We have to kind of find ways to build our own individual resilience. So, did that help? Okay.
Thank you.
Thank you, guys.
For today, a big thank you to our presenters here. That was wonderful. And we may have some time at the very end to continue asking questions. I want to introduce to you Dr. Quinn Chipley, who is our counselor for our Health Sciences Center campus and is a wonderful resource for us here. And he's going to present for the last couple of minutes on suicide education.
Just real briefly, wanted to make sure that once you find that you do have a problem, and of course, the previous presentation was directed towards how can we actually reduce the number of stigmatizing and or traumatizing events that happen to people along the way, which will eventually reduce the burden which creates suicidality. But if you get along the way to where you're actually looking at a situation where you have someone who is suicidal, then we want to know what to do. I always distinguish between acute versus chronic suicidality, and that's pretty important because that's something you're going to find out in general practice of medicine anyway. You treat acute situations acutely, you treat chronic situations chronically. You don't want to go changing somebody's pH instantly. You don't want to go, changing their blood sugars instantly. And also, when you have somebody who has exhibited a personality style which tends to generate chronic suicidality, we don't treat them in exactly the same way. Most of what I'm going to be talking about today has to do with acute situations. We're not going to spend much time on that. Those chronic issues really tend to cluster within a couple of personality disorders and what we call cluster B disorders. And they will, you really want to get them to someone who's going to be able to help manage them as much as is possible in an ongoing outpatient basis so that we don't reinforce a particular pattern for them. But for the acute things, and that's when you have someone who's been previously a fairly normal functioning and suddenly they start exhibiting certain aspects and symptoms and signs, we want to be able to respond quickly. The protective factors, and this is in general, this is not just with an LGBT population, moderate to strong social connections. Youth is still actually protective, even within the LGBT population. For them, it's still more protective than being old and LGBT. Age just simply increases it because you increase other stressors in life along the way. So physical and mental health obviously tend to be protective. Having religious inhibitions against suicide actually is protective. Having responsibility, that is for children or for pets, is protective. And we're going to talk about why that's important as a sign. Those that are at risk, top of the list always, no matter what your subpopulations are, those with substance abuse and addiction, of which alcohol use disorders predominant. They just are. It's about 20 times the risk. Most every attempt that shows up, usually about 50% of those have some sort of chemical on board. That's just what the stats are out of the emergency departments. So know that, and being able to do a good substance abuse and addiction questions along the way with your clients is going to be very important. Anyone who's had a prior suicide attempt is at a greater risk to attempt again. Now, that's not necessarily to say that anyone who's had a prior suicidal idea. And that's that interesting line between you go from actually thinking about it to actually attempting, because then you've gone from thought to practice, and like we know from anything in behavioral psychology, once you've practiced something, you're able to do it again better. And so that's just the basic rule. Anyone with a bipolar disorder, either 1 or 2, depression or severe anxiety, they're more likely. People with schizophrenia, if it's untreated. We've talked about the persons with minority status. That's really important. And you've already seen the figures on that. And any life-threatening illnesses, of course, HIV figures heavily within this population. So that's very important too. Also, any socially stigmatizing illnesses, and we've had a huge increase in syphilis within the community here within the last 5 years, and sometimes people find that to be very overwhelming. So just be sensitive to those issues as well, that it's going to raise their rate. Chronic pain, and we won't go into that so much with this population right now. Death of a spouse, a significant other, or a child, and very often within this population in particular, there may be someone who's died who has been concealed as significant. And therefore, that's really important to be aware of, what's going on. Ask along the way if you start seeing signs saying, is there anyone who's really been important to you that other people wouldn't have known was quite so important? Things like that. Losing a job abruptly, which can be because of status, that is LGBTQ, and academic failure. Usually it's not directly related to LGBTQ, but it can be secondary because of the pressures that people are feeling along the way. Some of the warning signs, talking about wanting to die or kill yourself, we pay attention to that. That's not just trying to get attention. People who talk about it are the people who do it. Okay, looking for a way to kill yourself, getting the means at hand. Hopelessness is huge. Very important to ask about the hope factor. And you can go at it from either direction. It's actually better to ask, on my experience, to say, well, can you see, in fact, that life will have some hope for you within the next several years? Because when they deny that one, and you've already phrased it in a positive manner, that means it's a pretty strong hopelessness. These different things all the way down, we've talked about increased use of drugs and alcohol, sleeping too little, sleeping too much. These all load with depression, rage, mood swings, and things of that nature. Those are all very important. If you start seeing them become very, very religious and they never have been before, or if they were always quite religious or moderately religious and suddenly they want to have nothing to do with it, either direction can be a warning sign. If you have a situation in which people start giving away pets, in particular, for no particular good reason that you can see, it's a very strong warning sign. So take that into account. Main thing I want to get to is how, as we say in the South, we want you to act right. So the first of all is to ask as directly as possible, are you thinking about killing yourself? And some of you have been through this before with me, but I'll get you to do it again. I want everybody to say that. Are you thinking about killing yourself? Are you thinking about killing yourself? Okay. Why do I want you to say that? Because once you've practiced, you're more likely to be able to do it again. Once it's gone over your lips, you'll be able to do that again in the future. Don't just ask, are you thinking about trying to hurt yourself? Because you're dealing with medically savvy people, and they say, no, it won't hurt at all. I know exactly how much benzo to actually infuse beforehand. Okay, so counsel the person as to what resources are available, and then take the person to help if they will go with you. And I call this the act right thing. And we have some resources here. For this medical center campus, we have an actual a special phone number, 852-PREV, which stands for pre-event. You can all spell that. If you can do that number, then you can actually get over to the special phone on my desk, and right now it's forwarded over to EPS, Emergency Psychiatry Services. So it actually goes to a real person. Or you can refer people to call 911. Okay? 7 counties have some hotlines too. That's all I really wanted to do. I just want to make sure we have some real practical things that you're able to do with that today if you need to. Thanks a lot.
Thank you so much, Dr. Chipley. We really appreciate that. So run on. I know you have a client. Thank you. So here at the end, I simply want to thank you all again for joining us. I have copies of our evaluation. This is so helpful for us to continue improving our certificate series. So if you haven't picked one up yet, meet me over here and I'll hand one out. Or if you've already filled yours out, I'll pick it up from you. Our speakers are right here. If you would like to cluster around them and ask some questions, I think we have a couple of minutes right here at the end. Thank you. Have a wonderful day. Well, it is important that people use the room.
Yeah. I do like it. I miss this room. Our room downstairs is not nearly so. It's weird. Yeah.
Well, I know some people that can work on that.
Yeah. Well, no, I mean, it's seriously, it's good to have the.
Computer lab, right?
Well, actually, for one, it's like this lecture, but it's broken up into little. You know.
For lecture, I
But it's I know it's so nice. Like when the first years are not don't need this room, and we're like way more fun. Otherwise, you're just screening your head around and weird screens and really spooky disembodied voices coming across like microphones out of nowhere.
Yeah, that is kind of funny. You're like, who's talking? I can't even see them.
I'll send this an